I think the key points are the current guidelines by the current establishment medical organizations like the Endocrine Society and WPATH are very conservative, especially relating to youth, for the reasons that I said, that we really depend on self-report and we want to be very deliberative in our approach. And we do not advocate any medical treatment before puberty. We do not advocate any treatment at all without mental health people on board, helping with the assessment as part of the conservative process of clarifying whether we really are trusting these kids to make sense.
Welcome to the East Anchorage Book Club. I'm your host, Andrew Gray. The purpose of this podcast is to tell the stories of Alaskans of interest and importance. This episode is part of an ongoing series regarding transgender rights. Today, our guest is Dr. Joshua Safer, who is the executive director of the Mount Sinai Center for Transgender Medicine and Surgery in New York. He is the founding medical director of the Center for Transgender Medicine and Surgery at Boston University School of Medicine, and he was the inaugural president of the United States Professional Association for Transgender Health. He serves on the Global Education Initiative for the World Professional Association for Transgender Health, otherwise known as WPATH. Dr. Safer was a co-author of the Endocrine Society Guidelines for the medical care of transgender patients. The inspiration for this trans rights series is 3 bills currently moving through the Alaska State House. One which bans trans girls from playing girls' sports, one which requires kids to get signed permission slips approving their preferred name and pronouns, and one which allows doctors to be sued up to 20 years after treating a trans youth. Alaska has many big problems: the pressing need to increase the funding of our public school system and finding a solution for an imminent energy crisis among them. But instead of working on those very real, very substantial problems, we are spending the last weeks of session debating whether trans youth exist and have rights. They do exist. They do have rights. Dr. Joshua Safer, welcome to the podcast.
Thank you for having me.
To get started, can we just learn a little bit about you?
I guess my evolution was somewhat random. I'm actually from Wisconsin historically, and I trained at the University of Wisconsin. I moved to Boston eventually. I was involved in academic medicine and endocrinology, and part of my role at Boston University, which is where I eventually ended up on faculty, was in the educational space. And it is not unusual for some of what would be considered to be the loose end areas of care that are not covered by others to fall to the educator. And so that's actually how I started seeing transgender people. Others weren't doing it. A person who took interest at Boston University had some patients, left the institution, and left me with his patients, and I had to become educated very quickly.
You were an endocrinologist by training?
Yes.
But not specifically interested in transgender medicine when you were starting out.
That's exactly right. I actually was focusing on thyroid and molecular biology research.
And then just by happenstance, you were on faculty in Boston, and this was the sort of orphan child endocrinology that you picked up.
I think that's a perfect way to say it. Yes.
And then I guess just because people wonder, they're like, you're not trans. This isn't something that that has like a personal investment for you. This was just what you happened to stumble into.
Yeah. The reality is I was charged at the time with determining if this was a reasonable thing for our group or for me to do. Then, this is 2004, in establishment medicine, the thinking included the idea that being trans was a mental health condition and therefore should be treated with various mental health appropriate solutions. And the idea that you would give medical interventions like hormones and surgeries would be inappropriate. We don't do that for other mental health concerns. And the idea was, are we just inappropriately treating people with a mental health concern, or is there a there? And if the former, then perhaps we at Boston University should shut down the clinic. And so I had to get educated very quickly, actually. And
how fast did it take for you to realize that this should be treated medically and not just as a mental health condition?
It worked out that then there were enough data to at least from my reading. One thing I felt, I may not know much about transgender medicine then, but I knew a lot about doctors and medicine and how academic medicine works. And the data we had at the time, still do, from treatment of intersex people with differences in sexual differentiation, and attempts to manipulate gender identity in them, I thought was strong enough to make the point that even if we don't know much else about it, gender identity is clearly part of people's brains and must be therefore coded. And it wouldn't be shocking to think that there are going to be some people for whom that coding is different than the coding for other elements of their biology associated with sexual reproduction. And then once you're there, then you can see the model. And then there are several ways you might envision treating somebody in that circumstance. And the observation is simply that the people who come forward and ask for interventions, who get hormones and surgeries in customized ways, do the best. And that's pretty much the story. And I found that compelling. And so not only did we not close the program, but I came back to the powers that be and said that A, I'm continuing to see these patients, and B, all of us need to be educated.
So you became the founding medical director of the Center for Transgender Medicine at Boston Medical Center.
Yes.
So
Yes.
you basically started this. And then you were also the inaugural president of the United States Professional Association for Transgender Health, USPATH.
Exactly.
Which to me, correct me if I'm wrong, those would be the folks that are basically determining the gold standard protocol for transgender medicine for everyone in America.
Yes, that's correct. So it's a small crowd. And so very quickly, somebody being actively engaged has an opportunity to influence events. And so I would characterize it as a lucky position for me to be able to actually do something useful on a larger stage.
Has the gold standard protocols changed much since 2004 to now?
Yeah, so the big change that certainly I've been pushing, based on what I just told you, is to reframe how we're thinking of care for transgender people from a mental health issue, which would have certain approaches, to recognizing that this is just simply part of people's biology. We all have gender identity, and it must be coded. And for most people, it align with other elements of the biology, and for some, it does not. And the treatments that help align the other biology, the body, with the brain biology, seem to work better. And that whole, what I'm describing there, that's a shift. Instead of counseling people and taking various mental health approaches to the circumstance, but rather just simply saying, oh, okay, that's interesting that happened to you. What do you want to do? Would hormones make this work better for you so that you can actually live according to how your brain biology is working? And short answer, people say yes. And really reframing it into much more of a conventional medical treatment strategy.
I want to generalize some of that research dealing with intersex people, and you can correct me or expand. But my understanding is that the old school way of treating most intersex folks at birth was to do surgical procedures that basically made them appear female. And then parents were taught, just raise this child as a girl. And what my understanding is that for many of those folks, as they grew up, they felt very uncomfortable being a young woman in society, that they had these real issues. I guess the way folks dealt with it was to not tell them. The parents were told, don't talk about it, don't tell them, just let them be normal, everyday girls. But so many of those folks never really felt like normal, everyday girls. And that was really the backbone of deciding that gender is more than just the way you appear. It's more than the way you're raised. There's many factors, but there's a lot of internal gender identity that is not brought on you by your parents, by society, or by the physical appearance of your body.
Yeah, so I think you summarized that very well. And I would be even stronger in how I say it. So the study that influences me the most is a study of certain specific kids who had something called cloacal exstrophy. They went to this big surgical center at Johns Hopkins in Baltimore. And exactly what you say, the surgeries for creating female genitals are better established than the surgeries for creating male genitals. And so if you could manipulate gender identity, either by having the parents say something or dressing people a certain way or whatever it might be, then go ahead and create the female genitals and get the parents enlisted and have them raise the kid in a sex stereotypical way, kind of like, for those who are old enough to remember, The Truman Show, that movie. And don't tell the kids about their medical history till they reach age 18. And that was the approach. And specifically with that study, there were 16 kids in that circumstance who had XY chromosomes. And if you assume transgender people are less than 1% or 1%, that would mean that maybe one of those kids would be trans or maybe none. Then, so of those 16 kids with XY chromosomes who received female genitals and whose parents were told to raise them as girls, 4 of them around junior high or so came to the surgeons and said, "Oh, I'm a boy," despite having a vagina, being told they were a girl by everyone around them. And so then they started investigating. And indeed, by the time they wrote the paper that influences me so much, everybody of the 16 kids who was in touch with them and who knew his medical history was saying he was a boy, and really just showing that whole concept to be an abysmal failure.
That brings up an interesting concept. So the reason why we're having this conversation is we have 3 anti-trans bills moving through the Alaska State House right now. They all move through the Judiciary Committee, which I serve on. And what folks who promote those bills would say, if you have an XY chromosome, then you are male and you should be raised as a male. And if you think you're not a male, then there's something wrong with you mentally, and vice versa. If you're XX chromosome, you are a girl, you should be raised as a girl. If your parents are allowing you to say that you're a boy, then your parents are not being good parents. We've heard this over and over again. And when I hear the study about the intersex and that all of these XY chromosome intersex folks who had female genitals because of the surgeries that they had as infants, all identifying as male, that almost seems to back up their ideology that the XY should mean that they're a male.
No. So I hear that. So if you were simply statistically to look at a group of people who have XY chromosomes, indeed, the overwhelming majority of the time, they will have male gender identity. So if you are betting and you only have chromosomes in front of you, then fine. But the key point that you can't change gender identity is the point that we take from that particular study. There are subsequent studies that further support that gender identity is a biological phenomenon. And so while it is true that most people have everything aligned, the model goes more like this. For sexual reproduction, it is really somewhat binary. It's mixing gametes from 2 sides, so sperm and eggs for humans. But think of it like this. The more we learn in science, the more complicated that regulation is. So it's not just that we mix those gametes. The example I think I'm currently using is squirrels. I'm sitting in New York City, squirrels in Central Park. So when the squirrels reproduce sexually, it's not that they throw their gametes in the air, blow like a dandelion in the spring and hope they find each other. No, they actually have organs and they have hormones to make them interested in getting together and combining the sperm and the eggs. And there's even more to it than that I think people hadn't recognized, which is that the male squirrel knows it's the male squirrel, and the female squirrel knows it's the female squirrel. They look a lot alike to me, but not to each other. And they, not only that, they know which gametes they're carrying and they know who's got the other gametes. And knowing which gamete you're carrying, that's what we're calling gender identity. And knowing who's got the other gametes, that's what we call sexual orientation. And that's biology, and that's part of the biology of sexual reproduction. And we know from things that we can see, like genitals and such, that all of it, when you have multiple genes associated with certain parts of sexual reproduction, sometimes you don't get all the genes that we think go with each other, including gender identity and sexual orientation genes. And again, that could be more complicated than I'm saying it, but it's most simplistic that. And if anybody who deals with animals sees what we've believed were homosexual behavior, let's say, among livestock or animals in the wild. And so we can see that there is this variation naturally. And some of what we're calling homosexual behavior is probably trans behavior, but we just can't talk to the animals. And so we didn't realize. And we have that too, clearly, as part of as the natural phenomenon of human biology. It's just that we can all describe it to each other, and we superimpose all our human thoughts on it a little bit and create a little more complexity, probably those squirrels are experiencing, but same idea.
I'd like to dive into the treatment of youth, because that's really what all three of the bills in the Alaska legislature right now target. Even last night, we had a late night floor session, and one of the sponsors of one of the bills was saying that I don't care for kids because I support giving hormone blockers and hormones to kids before they know what they're doing, and that I want to, quote, chop off their body parts, end quote. And my limited understanding of somebody who's been cramming this for the past few weeks is that there have been real changes in approaches to treating youth. And when we look at the UK, the Netherlands, Norway, Sweden, and Finland, that the Dutch protocol, that there has been some pushback on that. However, my understanding is that America hasn't really pulled back in the same way that those 5 countries have. And so I guess, can you talk about what is the current standard for treating trans youth, and if we have made any changes in the last few years?
So the current standard is very conservative. And it's not questioning that model that I just described so much. It's that you can only know somebody's gender identity from self-report. And so you're depending on them being able to understand what gender identity is, be able to explain their gender identity to you in a way that you feel trusting that you're really understanding what they mean, understand the implications of some of the treatments, because hormones and surgeries do have implications, especially, like many people are aware, with regard to fertility. And you depend on a certain level of maturity before you embark on any of that. And for adults, it could be more straightforward. And I'll tell you, as in practice, I'm an endocrinologist and I see quite a few adult patients. And unless they have a mental health reason to not be telling me things clearly, they overwhelmingly are. And we can be methodical and intentional and deliberative in terms of their treatment so that they don't rush into things faster than they want. They're straightforward. With youth, the issue is, how much are we trusting those kids? And it's, again, not doubting that they're trans. It's simply moving a little bit more slowly, because we're saying, hey, A, do you know what you're talking about? B, have you considered all the implications? And are we doing that in a deliberative way? So the current approach, what gets called gender affirming care, is broad umbrella for basically taking care of trans kids and being respectful of them. It starts out, if they're before puberty, then we don't do any medical intervention at all. And then it's all talking, and maybe we let them act in the roles in society that seem natural to them. Like you heard me say, the model is that gender identity is biological. So the fear that they're going to brainwash themselves if we let them cut their hair a certain way or wear certain clothes does not seem to be a valid concern, not in the long run. I'm not saying there's not
always
peer
done
pressure.
that. I'm curious if we've always avoided any sort of medical care prior to puberty.
We have always avoided medical care prior to puberty. That's not changed. The only thing that's changed a little bit is that we used to be more insistent that kids live according to the genitals that they have and call that their sex and hang out with those kids or wear the haircut that matches, where now we're more liberal in that space, at least some of us are. Okay, when the kids start to hit puberty, that's when there becomes some opportunity for intervention. Because if you've got a transgender boy, so female to male, then that kid is going to start to hit puberty whenever that is, age 10, 11, and is going to stop growing and is going to start to grow breasts. And most of those kids who tell you they're trans at those early ages are trans and really want to do something about it. And so if I had a way to have them not grow those breasts, and if I had a way to let them grow a little longer and be a little taller, then I like to do that. And so we have an agent, that's what people, colloquially call puberty blockers, where we delay puberty essentially. They're totally reversible in the sense that if the kid is wrong, meaning they're not trans or they're trans, but they don't want to do anything about it or whatever, and we've rushed them to puberty blockers and this is the wrong thing to do, we can stop them and they will just go into their natural puberty without a problem.
Is there a limit? Is there a limit to how long you can delay puberty and still reverse it completely?
I don't think there's a limit. Certainly as an endocrinologist, I've seen people who, not with puberty blockers, but who have naturally have had puberty not happen for some reason. We give them hormones sometimes years later and get everything to work. Problem is that sex steroids, sex hormones are very important for bone health. And so I think most of us in the field would be uncomfortable not having you be exposed to sex hormones, whatever it is, your natural hormones or hormones we give you, for more than a year or two. So that's the limit for puberty blockers.
Gotcha. So let's say, for example, you have what you're talking about, a trans boy, female to male, age 11, you block puberty for a couple of years, and then you give them testosterone. When they get the testosterone, do they go through puberty as a male? Is it an equivalent puberty for them when you're giving them the testosterone via injection?
The answer is that yes and no in terms of whether it's an equivalent puberty. Certainly in terms of appearance, they will masculinize in very conventional ways. Facial hair, the voice will drop, there will be muscle development. And so that, yes, the height, the height we do not, we're not getting them to what would be the predicted height if they've had a total male puberty. So clearly there's some hybrid reality there. Maybe it's just that we're starting too late. I don't know. But anyway, that's the circumstance we observe. And then genitals that grew when they were in their mother's womb don't reverse. And not everything is hormone based. So the external genitals, vagina, penis, those are hormone driven. And so there is some influence there. But uterus and ovaries, that's a completely different gene. So they're not affected at all.
And just for completeness, a trans girl, it would work the same way. If you blocked puberty for a year and then started estrogen, the estrogen would drive puberty for them. So they would still have puberty. It would just be estrogen driven as opposed to testosterone driven.
That's exactly right. And so we would end up then with same kind of thing, some mixed reality. If they've got some height already, they wouldn't lose that height. They will develop breast growth, their facial features, the relative musculature will be what we think of as female pattern. If you start it soon enough, you might even get their hips to widen, but they won't develop a uterus or ovaries because that's a different gene.
Two questions. The first is just if you can dispel or comment on some stuff that I read on the internet. I was reading about a couple of cases where trans girls were given puberty blockers very early and prior to the starting of any puberty themselves, and that they were not able to have an orgasm because they had never had an orgasm. They did the puberty blockers, and for some reason, this somehow stunted their development in such a way that they were incapable of having an orgasm. And if this was a concern in the community, if you could talk about that at all.
Yeah, I don't have any data, so I don't know how prevalent that is. And certainly most of the trans girls who go through this process seem to do fine, but I don't want to call it a myth because I don't have data for it being a myth. And I do actually think it's a valid fear that we would want to avoid. I'll make this observation. Testosterone increases sexual thoughts. And when we take transgender boys, so female to male, we give them testosterone, even at a very early age, they have increased sexual thoughts, like is true for all people you give testosterone to pretty much. And sexual activity becomes a priority, and they do their sexual function, they report, is pretty good. It's improved. They're like making a project of it when they go home at night. And by contrast, the transgender girls, where we're decreasing their testosterone, they're having fewer sexual thoughts. And the observation is that when we then later, if we do, let's say, a genital reconstruction surgery, that's create a vagina where there was a penis. So that surgery, by the way, simplistically for your listeners, they should think of it as making the penis inside out as opposed to cutting it off, because that's actually what we're doing. All the skin and the nerves are maintained. We're actually trying to preserve sexual function. And the people who have good sexual function prior to that surgery should have good sexual function afterwards as well. So when they know how to stimulate themselves to have an orgasm, then even with their rearranged genitals and the nerves in slightly different locations, they identify those nerves and they can have good sexual function. The fear is that if you take somebody who has not yet developed to the point where they really know what they're doing, and then you go on to rearrange their genitals, is that just too many barriers? And are some of that going to have a problem? And it's like you hear me say, I take a pretty conservative view, actually, and I would not want to call that a myth. I would call that a fear, and there might be some people in that circumstance, and that might be an argument to delay treatment for transgender girls until they've reached that point.
Speaking of surgery, I know we do not do gender affirming surgery in Alaska. And for anybody, we just don't have that surgery available in the state. I'm just curious about how prevalent gender affirming surgery is for minors in the country, and if it's something that you recommend.
So it's gender affirming surgeries. Let's be clear. There are multiple surgeries that cover all elements of the body. And as a rough rule, things that the legislature should consider, like I said already, medical treatment before puberty, not happening. Puberty blockers, I say they're reversible, but I think we need to be cautious because most of the kids who get those puberty blockers go on to other hormones. So we do already want to have some of those fertility and sexual function thoughts that you raised as we move them forward. And I think those are probably not decisions that should be made in the legislature, but those absolutely should be conversations among the medical folks in doing the right thing for these kids. And then to answer the last question, surgeries for minors are incredibly rare. And the surgeries that we do on minors are almost exclusively limited to some chest masculinizing surgeries for older trans boys. So older teenagers, transgender boys, female to male, grew breasts when they didn't want to. They've been living as a boy all along. Everybody's on board, the parents, the medical folks. These are not the fraught cases, shall we say. So with everything lined up, the narrow circumstance of some of these older transgender boys are having the chest masculinizing surgery and removing the female breasts. That's about it.
Are there any last misconceptions that folks have that you would like to dispel? Any last words that you'd like to give to our listeners about this issue?
Yeah, I think it's mostly summarizing what we just discussed. But I think the key points are the current guidelines by the current establishment medical organizations like the Endocrine Society and WPATH are very conservative, especially relating to youth, for the reasons that I said, that we really depend on self-report and we want to be very deliberative in our approach. And we do not advocate any medical treatment before puberty. We do not advocate any treatment at all without mental health people on board, helping with the assessment as part of the conservative process of clarifying whether we really are trusting these kids to make sense. Certainly my program here at Mount Sinai, when I have a kid who's beginning some sort of an intervention, even a little older, like in college, saying that they're not interested in fertility, and I have a parent in the room saying, oh, yes, we'll be doing some sperm banking.
Right.
Preserving fertility really is a priority. That kind of group decision, shall we call it, that's a little more conservative than maybe the kid is feeling or advocated. And so the medical field, I think, is more aligned with what society would want to be hearing than I think sometimes people recognize.
Hey, one final question, because it's definitely something that we see more in society today. How do you deal with youth that identify as non-binary?
Yeah, I think that it ends up being two different questions. To what degree your gender identity is not aligned with some of the rest of your biology, and what interventions we might consider, and how you want to label yourself. So I do find that, for example, even in the past, when people were labeling themselves in very binary ways, that we definitely had people looking for lower dose regimens, partial regimens, and some hormones, but not surgery, things like that. And we always customize our approach to the patient. And at the beginning of the conversation, we talked about the fact that I had worked in thyroid heavily before this. That was true for thyroid too. And I use those same models in terms of thinking about customizing care. That's been true and it continues to be true. So now I have more kids come to me and say, oh, I'm non-binary and I'm using they pronouns. I'm an endocrinologist. And so why are they coming to me? Usually for hormones. And I have to ask the second question, which is, okay, and what is it that we're doing? And I would say that a majority of the kids who come to me telling me that they're non-binary and using they pronouns are still looking for binary hormones. And that crowd that I referenced a moment ago that I used to see more of, they still exist. I still have people very binary in their identification looking for much more modest regimens. And so I don't know that there's really a practical difference if we're customizing to the patient anyway.
Dr. Joshua Safer, thank you so much for being on the show today. Thank you for your time. Thank you for your expertise. I'm really honored to have you here.
It's my pleasure.
Thank you so much for listening. If you like what you heard, please subscribe, rate, and review us. To contact me, email rep.andrew.gray@aklec.gov or call our office at 907-465-4940.